First of all, I bring greetings from Kochi. Thank the organizers and Novo Nordisk for giving me this opportunity to be here in Chennai. Nice to be back. Always um, wonderful to visit Chennai from time to time and see the wonderful changes that's happening here. So, I'm here to talk to you about a current maxim that we have started using in diabetes, both, when you talk about diabetes and its management, which is the CKM syndrome, which stands for cardiac kidney metabolic syndrome. We also call it CARME syndrome, that is cardiac renal metabolic syndrome also. So if I were to put it, I would like to draw an analogy to the Palgama attack when I look at the CKM syndrome. And why do I say that? So if you look at the initiator, so if you want to call, let's say, forgive me for taking names, but then, maybe we'll imagine that Pakistan is the initiator, and then you have the amplifiers, so they are the terrorists maybe, if you want to look at it, and who takes the hit, the 26, 28 people who died, are the outcome of, what happened. So what do we do about it? What can we, what are our resources in front of us? So obviously, we need to look at the initiator, and I've given you a good way to remember what the initiator can be, and this is, in our case, in diabetes, it can be, uncontrolled blood sugars, your obesity, your renal health, and eventually your cardiovascular system takes a hit. So what can we do to look at the initiator first? And I think since we're talking about oral semaglutide, and I'm sure nobody in this room is unaware of oral semaglutide, but I want to draw your attention to the blood vessels and to the brain primarily. Obviously, the GLP-1 or GLP-1 agonist works through your gut, but then the spotlight is on the blood vessels because it's the endothelium that the GLP-1 receptor agonists protect, and you'll see the case in the point as to why that is. But it works primarily through your brain and reduces the appetite and therefore reduces the adiposity. So much for addressing the initiator part of it. I'm going to skip this slide, but so much so that all these informed, wise bodies like the European study for liver, they have addressed GLP-1 based therapies and semaglutide as one of the potent agents for treating chronic liver disease or NAFLD NASH. I'm to give another talk this evening where I'm also going to discuss other agents, but I know fully well that semaglutide or GLP-1 receptor agonist can be a very effective treatment for NAFLD NASH. Then the European Society for Cardiology has said that GLP-1 is a must for people for people with existing coronary artery disease or at risk for coronary artery disease. You must look at GLP-1 based therapies. The KDIGO, that is the Kidney Foundation, also have been pitching for GLP-1 based therapies, and we know why. And overall, the AASD has put together the cardiac and renal comorbidities as a must for GLP-1 based therapies. So, like I said, one of the ammunition we have against the initiators. So if our rapid response team or the anti-terrorist squad want to look for, ammunition against these terrorists, and we are waging a war as well. So semaglutide can be one of those agents that we use as ammunition to wage our war, and you can see a lot of studies backing these basic protective elements of semaglutide. And if you refer back to all the pioneer studies, but I'm not going to look into that. They have about 6 to 7 pioneer studies looking at the efficacy and safety of oral semaglutide. And before that, on the back of sustained studies which looked at injectable semaglutide, or popularly known as Ozempic. So therefore, the synopsis of the pioneer studies are that you can look at something like a 1.5% reduction in A1C, a weight loss of something like 5 kilograms, and if the baseline A1Cs are over 8%, then 9%, sorry, you can look at a A1C reduction of over 2.6%. And that's the case with most of the drugs also. But what it says is that it's a very potent diabetic therapy, the GLP-1 based therapies, and especially the oral semaglutide. And if you can look at the pioneer studies, and if you see how it matches against, for instance, an SGLT2 or a DPP-4 inhibitor, they seem to be more effective in terms of A1C reduction as well as weight loss. And this is the weight. If you drill down to the weight loss part, not only do you have overall fat percentage reduction, the visceral adiposity comes down also, but not at the expense of your muscular tissue or the protein content in your body. So it leaves the skeletal muscle intact, and that is critical, because the skeletal muscle also is in many ways supportive of a good metabolic system. So you should not lose the skeletal metabolic tissue. So that's what semaglutide does, and this is basically the hemodynamic benefits. But I'm more excited about the inflammatory process, the endothelial protection that the GLP-1 based therapies have. The hemodynamic part, yes, of course, but then maybe the SGLT2 equally needs a mention. But the endothelial part is what the GLP-1 has an advantage over. And if you look at the amplifier, I told you the terrorists are the, in a way for you to remember the amplifier. Here it's the chronic kidney disease. And if you look at the studies that have been done, the pioneer studies, as well as the SOUL study, which is looked at cardiovascular health as well as the renal aspects of it. And you see huge advantages in terms of reduction or maintaining the eGFR, preventing the eGFR from going down, and also the urine albumin excretion ratio seems to be stabilized, improvement, prevents worsening, etc., etc. So therefore, the renal benefits are also there, and so much so that the KDIGO has strongly advocated the use of semaglutide in these patients. So that's that. And then this is the Pioneer 6 study, which looked at this is the CVOT study for Pioneer 6, and you can see a 21% reduction in MACE, and that MACE reduction primarily is driven from a reduction in non-fatal MI. So this is where I want you to draw a distinction between an SGLT2 and a GLP-1 based therapy. Here, it's mostly the coronary artery disease that you seem to get a benefit from, whereas the SGLT2 reduce the heart failure and therefore the all-cause death. So what you're seeing here is that it is the basic endothelial protection that is actually giving you all the benefits. So it makes, I think, good sense to combine a GLP-1 receptor agonist like some oral semaglutide and a SGLT2 inhibitor, which can look at the hemodynamic part. And that's the distinction I wanted to make. And this is the SOUL study. We'll just sign off with the SOUL study. Now, what did the SOUL study do different from Pioneer 6 study? Here, they recruited people with existing, or Pioneer 6 recruited people with existing coronary artery disease. Here, this looked at the primary prevention also. So people at risk for, they need not have existing coronary artery disease, but they also at risk for disease. And here also you found a huge benefit in terms of the renal. So they looked at the renal benefits of the drug as well, and eventually they concluded by a 14% reduction here as well. So primary as opposed to secondary, you can imagine here we are including people who do not have coronary artery disease, but still you see a 14% reduction. Very compelling here in terms of the cardiac protection. And here you see the non-fatal MI also came down by 26%. And that's the case in the point I was trying to make. And here, the benefits, the MACE benefits, you see maximum, the ones who had A1C of over 8% seem to benefit the most. But you can see in all categories, it did well, but majority or maximum benefit you saw in patients with A1C of over 8%. And this is the kidney data also. So you can see on 5 parameters, that is the need for renal replacement, more than 50% reduction in EGFR, all that came down was statistically relevant when you compared with placebo. So 2 protections, the cardiac protection as well as the kidney protection. So yeah, this is again the MACE, regardless of whether SGLT2 was used or not. Yeah, so, but one thing you must remember, we said all the good things, but the adverse events when compared to placebo was slightly higher. And you would expect that with GLP-1 based therapies, the GI side effects are there, you cannot deny it, and no wishing it away. So there was a higher level of discontinuation of the drug when you compared to placebo, and that is there. So you need to start slow, go slow, and educate the patients about the possible GI side effects. When I start 10 patients on GLP-1 based therapies, 9 of them continue, maybe 1 needs to drop out, and that is real. So again, taking the analogy of the Palgama attack, I think if we were to use that in our paradigm, the oral semaglutide checks all the boxes, very effective, reduces the body weight, and I think the body weight is crucial to all the adverse effects of diabetes. And if you address the weight part of it, half the job done. And the CV benefits are there. I shared with you the Pioneer 6 as well as the SOUL studies, and you have other pleiotropic benefits that come along with the benefits that I just stated. Risk of hypoglycemia is very low. Thank you.